Hello everyone, virtually and not on the day. Sorry I can't be with you today, and I hope you're enjoying it so far. I was part of the faculty in the first wave a couple of years ago and really enjoyed seeing the improvement and the energy and the passion of the teams in person and also virtually, obviously when the pandemic started. So it's great that you're all here, and I am just going to talk a little bit to you about well, measurement, audit, quality improvement, quality assurance, all those things. What does it actually mean? So if we look at successful organizations, I think this is a really nice couple of summaries here. So if you look at the Rubik's Cube, you know, you hear about improvement. That's the wave that we're riding at the moment, you know, in the NHS, everything's QI. We look at judgment, which is the sort of old school, unsexy bit, which is the quality assurance. Maybe sometimes that's where clinical audit is put in, but there's also research as well. Now, all of those have a place within the NHS. One is not sexier than the other. And I think the best way of looking at this is looking at it from a facet point of view. So you can see these different faces, different facets of quality where research, improvement and judgment, they're all have their separate space, but they're all combined as well. And they do make up a whole. And literature is showing us actually that, you know, the successful organizations that work within the NHS and improve patient outcomes on a continuous basis, you know, are the ones that combine all of those. And I guess with the audit bit, for me as a Commissioner of National Clinical Audits, you know, a benchmark is a noun. However, benchmarking is a verb that actually requires exploration and investigation of why the benchmark number was achieved. So keep that in mind. And the last thing in terms of literature and evidence-based that I just want to highlight, you know, a study came out where hospitals or private practices or GP practices, there are three things that really stand out when researchers looked at continuous quality improvement. And that was systematic data-guided activities, iterative development and testing, and designing with local conditions in mind. So if you think about systematic data-guided activities, that's epilepsy 12. If you think about iterative development and testing, that's the HQIP program that you're on. And if you're thinking about designing with local conditions in mind, that is also the HQIP program. So, you know, I think for me as a commissioner, this is really exciting because this is the interplay, you know, of what you're going through now through this program offered by the RCPCH, as in HQIP, with the national audit which we commission. And it's great that this is coming together because, you know, we typically look at structure and processes of care within national clinical audits. You know, the CQC uses this for various purposes. Your own hospital boards, committees, safety committees, quality committees, and QI departments. But it's this culture element that really turns positive patient outcomes into fruition. So you can do all the audits you want, you can do all the QI testing you want, but if you haven't got a culture where you as a team, as an individual, as a hospital or as a service ask yourself, do we know how good we are? Do we know where we stand relative to the best? Do we know where and why variation exists? And over time, you know, what has changed and what's needing to change? And then if we're doing quality improvement or we're striving for improvement, what's working? If you can't answer those questions, I can tell you that you're either just doing QI, you're just doing the clinical audit, and you're not combining them all. And I think all of those elements need to be combined because that is where you get organizations that strive for improvement and improvement in patient outcomes. And of course, you need some skills, you need some knowledge, which hopefully this program will either build up, give you, or spark some ideas off. And you need leadership and the right culture to support you to devote time to this, and the resources. Improvement takes time and it takes resources. It's not a silver bullet. So what we're hoping is that through this program, you're synchronizing participating in national clinical audit and quality improvement, this iterative testing. And what you're actually doing is trying to improve and sustain your epilepsy care for the benefit of the children and young people that you're serving. So to summarize and to finish, there is only one national data set, and that's Epilepsy 12, where you can look at benchmarking yourselves against others. Yes, it is retrospective, although the team are planning on some, novel dashboards and some real-time focus, which might be around the corner, where you can always access your data, but it's only as good as the data that you put in. But I think, what we're seeing is doctors, nurses, pediatricians, the teams that do enter data into national clinical audits, they start getting ideas about what to improve. They get national reports, they get local data, they also hear and combine patient experience with their national data results, and they make connections with other teams that are improving or have improved or are really achieving the top level of performance, shall we say, in process and structural measures. So in summary, I know most of you are putting data in, and most of you are reviewing your national clinical audit data. So if you're not, start doing it and start making this part of your QI or continuous improvement behavior. Some of the things that Pat and others have talked about, particularly Emma, and combining it, an epilepsy action, combining it with a patient voice. So I hope you enjoy the rest of the day. Sorry I can't be there with you. Obviously, you'll be able to get further info from Mel and the team. If you do want to get in touch with me, here are my details, and I look forward to working with you over the course of the program.